Welcome to the Living Medicine podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
All right. Hello, everybody. I am excited about today. I'm here with Dr. Nicolas Grundmann from Ember Health. And just to tell you a little bit again, this is Dr. Sandy Newis. And this show is sponsored by Living Medicine Institute, which is a training and resource program for clinical and medical professionals. And it's a direct pathway to practice and to meet all of your needs under the one umbrella. So I want to introduce Dr. Grundmann. Is it okay what do you prefer to be called? Seems like people call you all kinds of different things. Okay. Okay, good.
Yeah.
Good. So I want to introduce Nico. He's a board-certified emergency medicine physician, really focused on improving how healthcare systems operate for those who need it the most. So he came from suburban California to inner city New York and then went to rural West Virginia and got really frustrated with how he was treating acute symptoms of mental health really without the long-term solutions. After, many years of working with it in the emergency room, he really realized about how safe ketamine was and prompted continuous research of the drug's efficacy for other conditions, including depression. And that led to the founding of Ember Health. And one of the things that I am aware is that one of the things I really admire about you and about Ember is really this kind of data-driven piece. So that I'm hoping that will kind of inform what we're doing. And just to let the listeners know, I actually came to be aware of what Nico was doing, like quite literally on a forum, Psych-E, for those of you who are unaware of it. It's a nice Google Groups forum where there was some discussion about different ways of approach and, is it better to have a therapist or not therapist, and the efficacy of ketamine in general. And an article came out where it basically said that there was no difference between ketamine or treatment as usual. And you gave this exceptionally well articulated response about all of the different factors that would have played into those results that really captured my eye with your attention to the research methodology. And so I was really grateful for that. I brought it into our training program at Living Medicine Institute and we processed through it. So thank you for that. So welcome to the show. Appreciate you being here.
It's absolutely my pleasure and appreciate the kind words. Yeah, that was an article that was getting a lot of attention in the national press about how kind of ketamine failed in the inpatient setting. And as I wrote about it, and as we've talked about, really felt like an odd takeaway given all of the nuances of the study and all of the methodology there. So glad it was well received.
Good. And maybe, I want to just ask you, because I ask everybody this, and I think it's such an interesting question about your pathway into the field and what's driven you into this. But let's bookmark and just go back to that, because some of those considerations I think are really important to just highlight for the people who are listening. So how did you, I got the bio part, right? And we have a lot of ER docs who come through our training program and, what they said about, how safe ketamine is and all of that. But what really drove you into this, into psychedelic medicine, into ketamine? Where do you stand? What's your passion in this?
I had a fairly eclectic life prior to Ember Health. The kind of short-ish version of this story is my parents did international development work when I was a kid.
Oh, nice.
I actually grew up in Africa for the most part. I was in Rwanda, I was in Morocco. And then as a young adult, after college, I went and did that work myself. So I worked for the Harvard AIDS Institute, was in Botswana for a year, was in Zambia for a year, was in South Africa for some time. I eventually started helping set up pediatric hospitals in Southeast Asia. So I had a whole miniature brief career in international health, mostly on the system side of things, like Ministry of Health type work. When I was doing that, it made me realize I really enjoyed clinical medicine. I enjoyed actually working with people, not just the systems. And so I went back to med school. I did an MD, MBA out at Stanford, focused on emergency medicine, as it was a nice bridge to the international world. And then that's eventually what brought me to New York. And so as you saw from my bio, California for about a decade, came to New York City, worked in the inner city hospital here in New York City, and then eventually found in a brief period of time where I was doing work in kind of rural America as well, getting a sense of what it was like to treat people in the middle of West Virginia, Minneapolis. All through that was this desire to do both the system side of things as well as the kind of individual person side of things. And as you saw from the bio, the reality with ketamine of being a medication I was using in the emergency department, very comfortable with it multiple times a shift would use it in that anesthetic range. And also seeing the emergency department as a place where people ended up with mental health issues, even though it's a really bad place to treat them.
Right.
We don't have great options for the suicidal, for the chronically depressed, in terms of the emergency department setting, even though that's where people do go. So those are what was kind of blending in the back of my mind. I was actually on shift in West Virginia. I still know the date of this event where I had started seeing some of the research on ketamine, seeing the academic press. I was on PubMed for a couple hours on a slow shift. And the following morning, I gave my wife a call and said, hey, this looks pretty good. This data looks really legitimate, but I'm not seeing very good options for this in New York City at the time. This was back in 2018. My wife was a management consultant, and so her whole job was systems and thinking through companies and making sure that kind of companies can be well-purposed for good. And so we actually ended up in the city having a workshop on that. She brought me into her space. We whiteboarded about what it would be like if this was something we wanted to try. That led to a pilot site that we decided to launch together. So my wife is my co-founder. We do this.
Oh, interesting. Okay. I did wonder because you have co-founder listed. So I wondered who your other co-founder was.
So she and I gave it a go in technically 2018. We started seeing patients in 2019. We ran the pilot for about 2 years. COVID was just starting. And then she came aboard full time in March of 2020. And from the pilot, we realized there was that there were actually about 100 or so patients we treated that did really well.
Interesting.
Saw that we can make an actual kind of clinical operations out of this. We could make payroll and support staff and make it all work. And then from there, we really leaned in. So at this point, Ember's got 5 locations here in New York City. We treated just above 2,500 people at this point.
Wow.
Run about 40,000 of these infusions at this point. Whole big 30-person team. That's the whole practice has grown quite considerably.
That's a lot. I mean, that's really, really big.
And there's an additional 30 people part-time, so 60 total. But yeah, it's grown well beyond the little corner office idea that she and I had back when we first talked about it. But yeah, the short version of how we got, relatively short version for how we got to here.
That's so okay. So what is it about Ember? One, like, what's the secret to your growth? Like, I mean, obviously we could do a whole thing on that, but a chunk of people who are watching are practice owners and, but then, kind of couched in what's special about Ember and what are you most proud about it?
We have so much that we're really proud of and I'm really proud of. It's the last 8 years of my life at this point, which is strange to think about in that way. Really from that first whiteboarding session, Tiffany's my wife, Tiffany and I were very conscious about wanting to ensure that some components were in place for the long run.
Yeah.
Yes, we can probably make this work as just a single mom and pop doctor's office. But going back to my systems thinking and her systems thinking, like that wasn't the end goal. The end goal for us was always to make a really big change in the world and doing things. Our first date was literally a conversation about what does it mean to live a life of purpose.
You might be my person.
Met in our 30s, we'd lived life a bit. We kind of quickly got to the same stance, but these were not light conversations, and she and I are not kind of small dreamers in terms of what we want to make on the world. And so for Ember, there's really 3 things from that first whiteboard that we wanted to be true. We wanted this to be an evidence-based practice that was still individualizing that evidence base to the people in front of us. We wanted it to be an ecosystem approach, so making sure that this was not done in a silo, but this is part of a larger care coordination community, an outpatient referral system where patients' whole care was being approached, not just a silo. And that this was a really patient-centered care. Any healthcare is better when you actually focus on the people. That's even more true for a treatment that by definition has an altered state of consciousness, where you need to really support somebody through that.
Yeah.
So those 3 pillars of evidence-based, patient-centered, ecosystem were things that we wanted to be true from day 0 that we've really kind of leaned in on as we've gotten bigger.
Well, and so, this is kind of maybe controversial, but let's just name it. So how do you see that as different from the majority of the ketamine treatment that's already out there? Because I'm coming in from the CAP side, ketamine-assisted psychotherapy, and there's an assumption that those kinds of things are going to be happening, but they are not always happening. And certainly on the other side, the kind of medical treatment, where there is often no therapeutic support, it can be very, very widely. So maybe just say,
Yeah.
Like, yes, that sounds great. And how is that different and unique?
So we didn't want people to be making false choices between different treatment options that were, at the time, the only things available in New York. We found back then, and still true to this day, that oftentimes the providers that really focus on individualized care don't necessarily follow the best evidence guidelines that we have. So, for example, route of administration. Intravenous ketamine has by far the most published data about it. So, we have these quotes on our websites because we actually were able to pull the statistics from clinicaltrials.gov, but something like 90% of all trials ever published on ketamine for mental health are the IV version.
Yeah.
And so an evidence-based kind of following that literature standard would require that being the intervention offered. Most people who focus on altered states or that patient-centered approach don't necessarily use the IV route. Some do, but not all. Similarly, if you only focus on evidence-based and only use intravenous ketamine, then you might not do anything with the altered state itself. You might not do intention setting or music therapy or really support a person. We have one-to-one care in our practice for all patients. They always have a clinician by their side for the entirety of the time that they're with us. That's often quite unusual for a purely medical practice, so to speak.
Right. And are they medical clinicians, therapy? Like what's the background of your clinicians? Like what does it take to be a clinician at Ember?
So the state of New York is pretty strict that any IV ketamine has to be done under the management of a physician. That varies obviously state to state.
Right. So not a PA, not a nurse. It's got to be a physician. Yeah. Okay.
So every one of our 90-minute visits has a doctor interacting with a patient for each and every time that they're in our space. About 30% of our visits, the doctor runs the whole thing. So it's the doctor in this space with the patient for the full 90-minute appointment. The other 70% are the doctor starts and then a nurse takes over. And the nurse is the one sitting in the room the whole time. All of our clinicians get an enormous amount of up training in managing difficult conversations, in psychotherapeutic support, in all of the intention setting and ritual aspects of this. So we start with people who are highly trained and well qualified, make sure that they have an additional set of skills that aren't inherent necessarily to nursing or clinical work.
Right.
But again, kind of building this bridge between disciplines so that people aren't making a false choice between one or the other is kind of how we wanted to go into this. The ecosystem thing is also one that
I just heard you say something important that I want to highlight. Like, not just because somebody's a medical provider doesn't necessarily mean that they have those, therapeutic skills in order to, what you said, have difficult conversations, navigate difficult things, provide the level of support. So I just want to highlight that. So awesome.
Yeah, I think we don't see this field being one of silos. And that was actually one of the reasons we founded Ember, was that generally speaking, let's talk about doctors specifically. So generally speaking, for physicians, physicians really good at intravenous ketamine, an intravenous anesthetic with medical monitoring and all the safety issues around it, are ER doctors, anesthesiologists, generally. Those are not the doctors that manage depression. Generally speaking, depression is managed by psychiatrists, primary care doctors in a lot of the US. And they do panel management, they do longitudinal care, they do all the assessments and stuff. So to make a single type of clinician be the only one who could do this work felt silly, because no person's background of residency and medical training was perfectly suited for this work. We wanted to build a cross-disciplinary approach where for our patients, we only work with patients who have an outside mental health care team. So we have to start the patient for treatment unless they have given a signed permission to speak to their therapist, psychiatrist, psychologist, whoever is there. We require that we talked to those providers before the first ketamine session with us.
Oh, interesting.
And that everybody's in agreement about this being a good treatment option for them.
Well, and I want to highlight how different that actually is, because I think a lot of places are like, oh, you should have a therapist. And of course, that's different, than working therapy as an integrated part of the process. And, the actual, like, not only do you say you should have a therapist, but you actually follow through, you actually talk to the person. So presumably there's some information exchange. So you're kind of ahead of the game in terms of starting and treatment goals and things like that. That takes the burden off the patient of also having to describe that. So great.
Yeah, when you asked about what makes us different, I wish that didn't make us different. I wish the default of care, but multidisciplinary care and care coordination, which are not unique to ketamine, those should be true for mental health more broadly, are really things that make this work better. And I would argue are should be required for this work, particularly given the overlapping fields of what people need as they enter into it. But yeah, that those three distinct pillars, you can find individuals and groups good at any one of those three. But I think what has made us special is that we've really made sure that we're good at all three of them.
Right. Yeah. Yeah. And then you talked about kind of, this data piece, or kind of like what, let's talk about the research and your background in this. But, how does research both inform what you do? Like you mentioned it about the IV ketamine is kind of a really, clear one. But then, this piece about you all at Ember have, what may be, I don't know for sure, you probably do, the largest kind of data set of individual ketamine clients that might exist, particularly in a medical clinic. And so that's a big deal. Like, how does that inform what you do? How does that incorporate into treatment? Could there be any limitations of that? Like, could it be limiting what you do on any level?
So that was part of that design from the beginning for scale thing, is we knew that there had been a bunch published, even back in 2018.
Yeah.
It's in hundreds of trials. It is not hyperbolic to state ketamine is the single most studied medication for depression in the last 30 years.
Seriously, I didn't know that. And I'm, at least loosely tracking it. That's important for people to understand, especially people who are trying to, sell in the independent, like.
So that's also on our website, the citations on our evidence page. We have 50% more studies on ketamine than we do on Zoloft.
Wow.
It is not.
That is so interesting. Like,
it's not a small volume of literature that informs this. Nevertheless,
right.
With any kind of evidence-based medicine, not everything has been studied. Not every component of this has an RCT on it. And so that was what we wanted from day zero to be true, is that not only were we practicing medicine in a way that was informed by the evidence, but that we're keeping ourselves honest and rigorous about how this continued to do for people. What did long-term care look like? What could we learn about medication interactions, safety profiles, et cetera? And so from really that pilot site, we built the whole practice off of a relational database system. So patients' day-to-day care with us was going, with their permission, was going into a database that allowed us to look at clinical outcomes, operational outcomes of how these folks did. And we do measurement-based care. So everybody gets a PHQ-9.
Okay.
Not going to argue that's the best tool in the world, but it is the one that Medicare uses, which is why we defaulted to using it. And then we have before, during, after, and we have continuous. Our patients at this point have provided roughly 6,000 years of life care that we've been able to track.
Interesting. How long do you track them?
As long as they're willing to continue to communicate with us.
Oh, interesting. And are they sent, like, is there like an auto something somehow set up that like prompts them at 3 months or something like that? Or because the reason I'm really curious, I like just getting into the kind of the nuts and bolts of some of that, because, I'm always out there advocating for data. I was trained as a psychotherapy outcome researcher, and also specifically how to do, these kinds of studies within the private sector, which is outside of the lab, which is what you're doing, kind of that practice research network thing. And it's hard. It's actually really hard. Like, these systems are hard. It's hard to manage. I mean, I assume with a lot of, automation now, it's easier, but still it's rough. So, how do you?
Very labor intensive. So yes, we have an IT tech system that we built and custom built. And yes, it does help kind of prod for who needs things. But a lot of it still goes back to humans. So every 2 weeks, we ask for a PHQ-9 from the patients in our system, that we're following, the people that we're helping. And if the person doesn't respond to the automated nudge, then a human, one of our nurses, will text them.
Okay. So you have an admin team that's
we have an entire, and they're clinicians, they're nurses and doctors both. So, and if they don't respond to those outreaches, we then reach out to their providers, and we actually get providers to chip in and say, hey, no, this person's doing okay. They're just out of town for the month. Or eventually, if somebody doesn't respond to us and tells us, I don't want to keep being tracked, by all means, that's clearly a signal that we're not going to try to bother them anymore. But the thing about depression is you have to assume that somebody's non-responsive because their depression came back.
Right. Not because they're doing awesome.
Right. The first thing that happens when people's symptoms spike is that they lose touch with the world, and they lose touch with their day-to-day. And so we treat the follow-up of our patients in that way, where if they're not following up, we actually have to step up our game because it means it's a signal that something bad is happening, and we need to make sure that the person's still okay. So yeah, that's why we have so much data and such long-term data, is our patients are not treat and release. These people don't come in for their initial visits and then go off to the distance. They have their initial sessions. We make a group decision with their providers around, yes, this was helpful or not. And if it was helpful, they stay getting check-ins with us at least every 2 weeks, if not more often, making sure that we're on top of how they're doing so that if things change and the depressive symptoms come back, that we're there to provide longitudinal care if necessary.
Good. Well, and I want to then also highlight the business aspects of that, right? Like, so, presumably, and people are always like, oh, I don't know if I want to, put the money into research, but let's flip hats now and think about that as a tool to extend care and keep clients in care, which again, I get that's not the only reason you're doing it, but this is where business meets good practice.
I would argue that anybody receiving ketamine care is going to need follow-up.
Yeah.
The data for that, and actually this is now our data that we're publishing, is that the average amount of time between booster visits is 6 weeks for all people who have, as a reminder, at Ember, we only treat patients who have a diagnosis of major depressive disorder or bipolar disorder.
Right.
So our ketamine is very specifically for MDD or BD. That's it. They can have other comorbidities, but everybody who's in treatment with us has had a clinician who's not paid by Ember. So this individual qualifies for clinical depression.
Okay.
For those people with the IV route of this and the doses we use, the average return time is 1 booster every 6 weeks.
Okay.
But there's a huge bell curve, that average.
And how are you tracking that? Like, are you watching kind of their numbers drop off? Are they self-reporting that? Like, how are you tracking that? Because I think most people have kind of like what I do in the clinic that I work with is typically I kind of ask the client, like we're tracking it together. I mean, because my clients, I'm still seeing them, most of them on a weekly basis for therapy. So I'm that person, that you're talking to, and the difference is I'm sitting in the session with them. But so we're tracking it, especially early on. But there's also still a fair amount of like, how often do you want to come in? What would you think your optimal range is?
We don't tend to give patients the agency to select without clinical input into when they come back.
Okay.
We really do time these sessions not as like, when do you think it'd be helpful? We time these sessions as like, when did your depressive symptoms start creeping back in?
Yeah.
And if you do feel some warning signs of the depressive symptoms, like name those for us. What are they? Are these things your provider has been worried about? Are these things that are not just, oh, I like ketamine every 2 weeks, so I should come in every 2 weeks? We really do try to back it so that the treatments are, we literally frame it as they're symptom-driven treatments, and they're depression symptom-driven treatments.
Are you training, like if you're, say I wasn't a ketamine provider and I was a therapist in New York City, are you training those people a little bit more how to notice those kinds of things? Like if somebody's a regular referral source for you or a regular, mental health provider for your clinic, do they just know? Or, how does that connection work? Because I think that's super important. Like, how do we individualize kind of the booster sessions with an awareness of the fact that they're individualized, but we have this general 6-week interval?
So the way that we think of our long-term care coordination is that the PHQ is a backstop. That number getting worse means that we're probably behind the game, because by definition, the PHQ is a 2-week retrospective. If you see a score go from where the patient's been in steady state at a 4 and now they're up to a 10, well, by definition, they've been feeling those symptoms for at least 2 weeks for the number to start to change. And so you're already on the back foot if the score improves. Now, the nice thing about sending somebody a PHQ every 2 weeks is you have a backstop.
Got it.
Say the patient didn't tell you, or say the provider didn't email us, and for some reason, a proactive communication wasn't initiated by the patient or their team, we then get the number and reach out to that person saying, hey, you haven't said anything to us, but we see this. How are you doing? Are things okay? A lot of that actually ends up being situational or contextual. And we actually add the PHQ-9 qualitative section. So we say, give us a little bit of a sentence or two about why things are this way. So if we see somebody's number go from a 4 to a 12, but they tell us that their pet just died.
Yeah.
Well, we'll ask if we think if they think the depression is going on, if the provider thinks the depression is going on, but we're not going to say, oh, you need ketamine right now, because ketamine is not going to help the situational issue. Like grief can be an appropriate emotion to feel, and it's not going to make you score well on a PHQ when you're sad.
Right.
But that's not depression. At the same time, if they show us a 4 to a 12 and they don't have anything, that's a trigger, or they don't have a clear situational aspect. Well, that probably is an indication that they should have come in. We need to get them back into treatment. We need to get them back caught up on stuff. And so I would, we clocked this a couple of years ago, but I don't remember the exact number. But when we actually like talk to our teams who are doing this on the ground, along the lines of 40 to 50% of their day-to-day is care coordination. It is not the direct provision of ketamine. It's the communicating with the team.
Sure. Right.
So that
yeah, because it's super resource intensive. I mean, that's why a lot of people don't do it.
Correct.
You know, just the simple thing of like calling the other provider, and then you have to play phone tag and you have to do the
Correct.
things and, you know, like the scheduling and just all of that, much less carving out, you know, X amount of time in order to do that. So I think that's really admirable. So one of the things that's coming, this is going to be a little bit of a sidebar into PTSD. Would that be okay?
Oh,
Like,
yeah.
Yeah. I really focus on PTSD, and I'm, you know, one of those people, like I'm really into kind of nervous system based approaches with trauma and PTSD. So not as much, so it's symptom, but it's different. And so, you know, kind of working in the physiology of the brain essentially. And my current working hypothesis in using ketamine for trauma and PTSD, like developmental trauma and traditional PTSD, is that a lot of times what I'm seeing is that the treatment-resistant depression people who present at ketamine clinics often have an underlying PTSD. So that's my first question. Are you seeing that? And have you given, you know, is that anything that you all are tracking, or what are your thoughts about that?
So from our most recent look at this, so we wanted to make sure that we were actually being forthright about practicing evidence-based medicine in the sense of like collecting data and then actually publishing on that to prove out what we're doing is actually legitimate. For ASKP, we've got 5 accepted presentations. One of them is about the kind of demographics of who we treat.
Yeah.
To answer your question about trauma, we found from our own patient panels that roughly a third of our patients have PTSD as a formalized diagnosis by their provider. So of the people we treat them for their MDD or their bipolar.
Right.
But 1 out of 3 of them have a concomitant PTSD diagnosis. And then if you look at the published literature more broadly, one of the clear predictors of ketamine response is childhood adverse events. And so that's not an Ember piece of data. That's actually already been published about having ACE is an increased likelihood of ketamine improving your depressive symptoms.
Oh, interesting. Okay. I was unaware of that.
Yeah.
I really would like to look at that data. That's awesome.
I can send you the source. It was one of the, that paper is probably 2018 at this point.
Okay.
It's been out there for a bit. What we have found in our approach at Ember is that if an individual has both trauma background and depression, easy to say yes to treatment. Good published data. Osman put out something like an 8,000 patient retrospective cohort of consolidating a bunch of ketamine clinics and saw that people with PTSD and depression both did very well with this. That matches our data very strongly. What I would argue we don't have great published evidence about is PTSD in isolation of depressive symptoms. There are small studies that does exist, but the kind of dozens and hundreds of papers have not yet reached that threshold for PTSD where depression isn't a concomitant issue. So if somebody called us and said, hey, I'm a war vet and I have PTSD, but I don't deal with depression at all. It's just the trauma of that issue.
Yeah.
They probably wouldn't initiate care for them with ketamine.
Okay, that makes sense, just based on the data. And so I'm curious about this particular piece. So one of the things that I am tracking is that I think it's possible, like, again, this is what my clinical anecdotal evidence, my clinical approach says, is that for some people, the depression is serving like a protective, it's tamping down the anxiety. And so for some people, what I see who have underlying trauma, that the depression remits quite quickly with ketamine. Say we're doing a series, you know, I generally do 3 to 6. And you know, that's another question that I have for you in time. And then a lot of times the depression will remit rather quickly, but then they feel more anxious. And my working hypothesis is that depression is kind of tamping it down. If we were going to use the IFS language, there'd be a part. It's a protective part. But essentially, the depression kind of developed in order to tamp that down. So if you're tracking data, I'm wondering if you see that, like an increase in reports of anxiety for PTSD clients, and what if you have thoughts about that.
So I can answer very clearly for people with anxiety disorder comorbidity. That one we actually surveyed our own patients and dove into quite a bit. So I mentioned a third of our patients have PTSD. 75% of our patients have a concomitant anxiety disorder.
Okay.
Very common to deal with both depression and anxiety. Again, if you have anxiety without depression, not start care for you. I don't think I don't think the evidence base in the literature would support ketamine for general anxiety disorders a monodiagnosis. But most people who have depression have something else in addition to that. And anxiety is a very So when we talk about this with clients on intake, when they ask us about what about my anxiety, how will that respond, what we've seen from our own patients is there's a couple of different paths that the anxiety can take. For most, on average, the symptoms improve in parallel. So for most people, as their depressive symptoms improve, their anxiety symptoms also improve. That's the kind of assumed path. But it's not always the case. There are patients who those initial treatments cause a rapid change in their depression, what you've just described, which is whether it's a frank increase in their anxiety or whether it's that the anxiety is much more noticeable.
That's my theory. Like they're just more aware of it. But again, I'm not tracking data, so.
Well, so when we asked people about that specifically, there was a very colorful way of describing it that a patient gave to me, which was that they were saying, okay, well, before ketamine, I had this anxiety in the room with me and I had this depression in the room with me and I was paying attention to both of them and they were both annoying me and it was difficult. And now this depression thing's gone, but the anxiety is the only thing in the room and is the only thing I can hear. I don't know if it's worse or the same, but it's the only thing I notice anymore. And that was just a very vivid way of describing whether it was frankly worse or not. By being the only residual symptoms or issues, it becomes something that people can focus on and think about a lot.
Well, and it makes sense if we start to think in terms of depression as being a dissociative response, in an effort to kind of tamp down the fight-flight mechanism. It makes sense.
And that was the last way that kind of contextualizing this that came out of that project we did, which was that for some patients, their anxiety actually did get worse. Like the symptom scores increased. But what they were describing was that the depression had acted like a blanket on their emotions. And that makes sense. Neurophysiologically, like depression is the state of reduced emotional bandwidth. When your emotional response system is not working because of chronic stress and trauma, you feel less. That is the theoretical protective mechanism of depression is that, well, you felt bad for so long, you should stop feeling. Why we hypothesize that this could have developed as a pathway. And if you now have a full emotional spectrum, but the spectrum of what you're feeling is chronic anxiety or acute fight or flight, those actually might be worse because they're not being tamped down.
Another thing another hypothesis that I have that I'm tracking is that people with underlying PTSD who, when the depression remits and they also start to feel better, there's often a process of kind of their brain, their mind interpreting like increased energy as being anxiety. So that mix between like excitement, well-being / anxiety gets mixed up. And I think that's where therapy can really come in and be helpful.
So we talk about for people for whom ketamine was helpful, we talk about the first few months after the initial visits, what we call the foundation of care, as the learning phase.
Oh, interesting.
And the reason we do this learning phase as a kind of structured time is that there's a lot people can be learning. For many patients, there's a lot of grief. In a weird way, if you've had depression for 40 years and suddenly you're not depressed, it is pretty normal to be thinking about the lost time. Relationships, all of that. And that can be quite emotionally volatile. That can feel really sad. And it's a legitimate form of grief. It is a net progress in that your depression is at bay or gone, and now you can feel grief, but it takes processing. And it is where a therapist in particular can be quite helpful there. there's also learning even to recognize what depression is. For many of our patients, they've had depression for so long that any negative emotion is called depression.
Right.
And it might be that grief example again. If you lose a loved one post-ketamine, you're going to feel sad. That's a warranted human response
Mm.
that is appropriate at times. It
Right.
just shouldn't be your default as
Yeah.
when you're depressed. Similarly, for many of our patients, when the anxiety, say, is more in focus, people have a need to relearn the coping mechanisms,
Mm.
to kind of relearn what you can do psychologically, what you can do yourself to help decrease either the triggers themselves or your response to those triggers. You have to relearn how to think and behave when you're in this new emotional state.
Mm.
Learning isn't just like Ember learning about your visit cadence and your symptoms over time. It's also the person learning about what it's like to live in this post-depression mindset.
Right.
And there's a lot there that needs to be taken with care, hence the kind of long-term coordination of stuff.
I love that because I see that, when people just go to a clinic, like I work with a fair amount of people in clinical practice who've done ketamine and they can tell that there's something there, but the gains aren't sustained. And one of the things I actually think is about learning like the skills and the capacity to live with the full range of emotion, particularly emotions associated with well-being or even just being okay. Like if I'm used to being depressed or I'm overwhelmed all the time and now I'm feeling things full spectrum, like how can I just become okay with being okay when things are okay, which is, a phrase that I love to use in therapy that I got from a friend of mine, Katie Asmus. So
Our teams are always really happy when we see a score on one of those surveys getting worse. We reach out to the person, we say, hey, are you okay? What's going on? When the answer is, no, I'm just having a bad week, but I'm okay.
oh, that's a big deal.
Really good sign.
That's a really big deal, right? It's
Yeah,
like I can be okay despite the fact that things are hard.
exactly. And our average client is a treatment-resistant depression person. They've had multiple rounds of meds, therapy, et cetera. And so for them to be able to recognize that distinction between a bad day or a bad week and a depressive state is a huge learning and really one of the things that we celebrate when that's something people are able to name.
I love that. Yeah, well, good. I'm glad that we clarified that because I've wondered about that, this specific kind of staying in that lane. I do understand that it's data driven. And, clinically, I'm also aware there's so many other things that go along with treatment resistant depression. So I'm glad that we talked about that. So let's switch gears to this therapist thing. So when you and I usually talk to people beforehand. So when we first talked, we kind of hit this place where, I'm training therapists and medical professionals too, but how to be in the room and actually be talking to the client most of the time, that's not everybody's view of what CAP is or ketamine assisted therapy is. And that's okay. But that's kind of the way that I'm advocating. And you're like, well, no, we don't actually let therapists in the room at all. And so let's just talk about that. That's an interesting thing. There could be lots of reasons for that, but let's go down there. How come?
Yeah, it goes back to the evidence-based thing for my kind of needing to see published things before I think it should be done at scale. Very few, if any, trials forced people to be in formal psychotherapy during the altered state.
Yeah.
The vast majority of published literature, particularly the IV literature, which is the bulk of it, is kind of medical administration of this without any in real time psychological support. Now that's a little bit disingenuous in the sense that many of these studies were done in hospitalized settings or in environments where there are psychological support through healthcare professionals, even if they aren't therapists. But that was the stance we took, is that, well, if the clinical trial data shows that this works really well and doesn't show studies where the therapist is needed in the clinical trial for this to be an outcome that is achieved, then what the data would suggest is that that's not a core required component of this. To make it a core required component of this, you'd have to see outcomes improve by a certain amount. So take the kind of baseline 70% IV effectiveness for a series of infusions at these right doses. You'd have to argue that cost and time burden of the therapist in the room improved outcomes to, say, 90% for it to be justifiable. My brain works in cost effectiveness ratios. That's what I did back in Sub-Saharan Africa work is okay, you have X dollars, X number of people who need HIV treatment. What's the medication that's going to cause the most people to achieve the most treatment success, given a fixed budget? And so a lot of what we did with Ember was that same orientation. If we added the cost of a therapist in the room, if we added the labor, if we added the requirement of engaging with somebody, would outcomes change enough to warrant the forced increase in costs and increased time and complexity? And I couldn't find any published evidence that would justify needing that as a component of care.
Super interesting, because the part that I got really intrigued by is you made one comment, and this may have just been a very small sample size, but you said, and when we did try it, brought in outside therapists, it generally didn't go well. So tell me about that.
Yeah. So I was less firm on everything I just said back in 2019 when we first started, because I was more of the orientation, well, it just probably hasn't been studied yet, or it hasn't yet been proven. And I'm still open to that. I would love to see somebody actually put a trial together that addresses this. The biggest challenge of putting a trial together is the degree of improvement you would need to see would have to be very big unless you wanted to do this trial for multiple thousands of people.
Right, exactly. Because you're already getting a baseline.
You're already getting enormous improvement. Right.
So to get something that's statistically significant through the add-on of the therapist would require a large sample size.
Exactly. And somewhat by definition, that means that A, it would be a very expensive trial, like many millions and millions of dollars trial. And B, if you need that many people participating to prove the point, then the no therapist condition is still a pretty good condition.
Right.
An outcome. Now, to answer what you brought up, so when we did, for a period of time, we said, okay, well, if your therapist wants to come in the room, we will let that occur.
Yeah.
And there were a couple of incidents that changed our mind. One is that the therapist who had come in office with us often didn't have any clear personal understanding of what this would be like. Overreact to situations. So a patient would be in that altered state. The therapist hadn't seen anybody in an altered state before. They would actually escalate and catastrophize about what's going on. And we'd have to be like, no, this is normal. This is part, like, please don't agitate them right now. Yeah. If you poke them, it will get worse, not better. And so it required an enormous increase in our kind of managing of the person who is in care and managing of their provider who is actually making things worse, not better. And then similarly, our ultimate thought process from the reason clinicians are in the room is that the medically adverse event rate for ketamine is not zero. It's low. We quote 1 in 1,000 sessions require a clinician intervention. There's some published evidence that's about the ballpark of this, where 1 in 1,000 times you need a doctor or nurse with a doctor aboard to act so that something really bad with heart rate and blood pressure doesn't happen.
Right.
And when you act as an ER doctor, you act quickly. And so the situations where I needed to actually put somebody on the monitor, and this was around and slowing it down and trying to take the patient. We're like, no, right now we got to check their heart rate and make sure that that's okay. And now we got to go manage their blood pressure and make sure that's okay.
Which would not be the same as therapy.
And so we found it to just be a easier blanket process to say that if you value therapy, which again, we promote patients being in therapy. I think pre-treatment therapy, post-treatment therapy, hard to argue with the published evidence that that's helpful. Particularly post-treatment, there's great, Wilkinson at Yale has some of the best kind of CBT post-ketamine papers that show that it really does increase the duration of outcomes and arguably improves the magnitude of outcomes. It's the therapy during the altered state that I haven't seen published evidence for, and given the potential for making things worse in the treatment session has been why we've drawn that threshold about not.
Well, and it's interesting because for me, it just simply confirms, it's more confirmatory than not, where I think that it does require specialized training to be able to be value added, to use kind of that language, to be value added, to improve outcomes. I think it does require specialized training because it's not the same as what you're doing in a traditional session. So I do see where you're coming from in terms of outside therapists just coming and sitting in and wanting to do what they normally do. So, I'm just kind of curious. I think it's probably an evolving conversation and just something to continue to ponder.
I think that our orientation for everything that we do is that if somebody demonstrates that there's a better way to do this, we'll follow that. our threshold for demonstration is a rigorous threshold. It's the kind of evidence-based medicine published in an academic journal, peer-reviewed. Like, we want to be practicing things that do have some degree of consensus behind them. But we're perfectly willing to change how we behave if we see somebody published to that degree.
And it's interesting because I think what I've been telling like prospective clients and what I say in training, and I do say that we don't have data to support this, but just clinically, I've been doing this work since 2019, and it's not like millions of clients, but solidly full time, is as the level of clinical complexity increases, and as the level of anxiety increases and underlying personality and attachment issues are more prevalent, then I think that the therapist can be increasingly value added, like straightforward treatment.
Yeah, I don't think you'd even need to argue about complexity. I think the data, so our own data, one of the things we're presenting at ASCP, having a therapist on your care team improves outcomes by about 10%.
Okay.
Now, that is not a specific licensure type. That is not a specific therapy modality. That is not a specific timing of one therapy session a week, two a week, et cetera. That's literally just having a provider, licensure of any kind of therapist, a team of people that Ember's coordinating with. Nice. Measurably improves treatment outcomes.
Great. Good.
And so, I don't ever think it would, ever is a strong statement. It would be hard to argue it harms an individual. The therapist is part of their care team. The reason we don't require it is because of the same way that it doesn't, it doesn't seem like not having a therapist is going to prevent some people from seeing benefit. And we have enough patients who have been through years, if not decades of therapy, where they've given up on therapy, that adding a roadblock of a therapist for an individual who doesn't feel that that's appropriate for them would likely prevent them from accessing a treatment that could really be helpful for them.
Right. Well, like one of the things that I did at a clinic that I used to work with was I would actually talk to the clients who came in intake as if they said, yeah, I might be interested in talking to a therapist. And I would just talk about it. Like you could have a therapist like outside, you could have a therapist who comes into the sessions with you that does a full on thing. You could not do it. Many people still choose not to do it. I just found it was an interesting dialogue that I had with a lot of people. So,
and that's often what we'll see is that we will say, generally speaking, therapy seems to make this work better. If you don't have a therapist right now, we're happy to introduce you to people who could be helpful. We do a lot of outbound referrals here in the New York City region. And if you don't want to have a therapist, that's fine too. We often find that after the first couple of visits, people have a different perspective on that too. If they do start to feel better, well, then they actually might very much be willing to engage in a therapist. So maybe after the first couple of sessions that they choose to do so, but we wouldn't have wanted to prevent them from seeking care.
Got it.
Roadblock in the beginning.
No, and that makes sense. And I would agree with you on that for sure, that it wouldn't be like you must do it this way. It's an option.
Well, a lot of people in our field are quite didactic about you must do it this way. And it's one of the things that we wanted to be a little bit gentler about in understanding that there's a lot of personal variation there.
Well, I love that. I love this data-driven approach. I love the conversation that we just had about PTSD and, all the different ways that you're doing it at Ember. So, we're close to the end of our time. So what else would you like to share? What are you excited about? What do you think is working? Where do you think the field needs to go?
The two biggest things I'm hoping for 2026, one is going to happen. So ASKP is putting together guidelines on if you're going to do ketamine for clinical depression, here's the kind of consensus version of what we think. And it's been a long, almost a year and a half project now. Nice. So look forward to some degree of standards that are being put out by the society about what seems to be kind of good evidence-based ways of practicing.
That's a big deal.
And then the second is with that, I think, well, keep me honest here, this will be the year where insurance reaches a tipping point and insurance coverage for IV becomes a bigger thing. That's a lot of what I spend my day-to-day doing. Yeah. A lot of insurance advocacy here in the Northeast. Seeing enough signals, including some of the stuff Ember is doing, where it looks as if traditional commercial insurances are going to start covering ketamine more broadly. And so that's the exciting thing.
Do you think they'll cover it at a rate that providers can afford to do it?
We wouldn't say yes to the insurance unless it would keep our payroll going. Yes, I do. Right. I think it's an uphill battle, but Blue Shield pays for IV ketamine in Massachusetts and Vermont. VA is paying for it in 22 states right now. Awesome. So the signals are there, and the work that we're doing is hopefully kind of push that forward. But the things I'm excited about are right now, the biggest barrier to access for ketamine is cost.
Right.
That's a hill I'm willing to die on for most people's statement that they don't do this because of the needing to pay for it out of pocket. And I do think that's coming close to changing, which will be a really cool time to be in the field.
Well, I just really want to honor you for building a successful business that provides excellent treatment that is really grounded in a foundation of data and research. And I mean, this is a wonderful model about how, good practice and, good development of evidence can actually result in also good business, and how all those things can come together in the private sector. And I just think that's awesome. Well done.
I really appreciate that. Yeah, it's been a wild last going on 8 years now. And we really look forward to where the next couple of years are going to take us.
Good. Well, thank you so much, Nico. Thank you for your time. Thank you for sharing your wisdom and your expertise. And I really appreciate it. So thank you so much for being a guest.
It's been my pleasure, Sandy. Thanks for the time.
Thank you. Bye-bye.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.